Uh, Now I'll invite Dr. Anand Parthasarthi. He's going to tell us about achieving good keratometry readings in post-kerato refractive surgery eyes. Dr. Nivian sir, your presentation is loaded.
Good morning, Dr. Bala and the chairperson. Thank you for inviting me to be a part of this lovely symposium. I keep the topic just to getting accurate K, and I'll start with one of my presentations. Of course, the simple answer is get a biometry, but the depth is probably in how you do it. No financial interest, but it would be nice to have some. So I guess getting accurate K is like nirvana for most surgeons, because that's an important part of achieving what you want to really get. And I'll start with this patient of mine who's in the business of government contracts, diagnosed to have cataract at another hospital, history of RK done 10 years back with a myopia for about -8. Now her children are doctors, a son is a clinical trial specialist, has done intensive research on different types of IOLs and me. Has read all my papers published, has a discussion with me on my PCR rates and number of premium IOL surgeries done, and son discusses the average post-operative results, including the confidence intervals. Now, doctor also wants to come in and observe surgery, and patient's pre-operative preparation included antibiotics, NSAIDs, and dilating drops, and my pre-operative included prayers to all the gods, including the 33 million gods that we have. Luckily for them and me, the surgery actually went off perfectly. Now, this is the pre-op pictures, and you can make out that the RK incisions are about 70 to 80% depth. And this is an important factor when you actually decide to plan, because if you have full depth or you have epithelial inclusions, you would probably need to be careful of where you place the incisions. But majority of the time, it's a good idea to do limbal or scleral incisions in post-RK patients. What was important was, if you can look at the keratometry, it's a fairly regular axis. So we did plan for a toric multifocal in this patient. And post-op, the results were quite good. In both the eyes, the patient got good vision with 6/9. At the end of the day, the hospital were happy with the income. The patient's family and I was happy with the outcome. Now, this research was done in the morning. So there is still some research being done on post-kerato refractive patients, because this is not in the normal range. Because for us, majority of the time we can hit 0.5 in a normal patient, but these patients require a bit more of focus, because these are post-refractive surgery, ectasias, post-keratoplasty, and post-RK would be about 80 to 90% of slightly more difficult patients, and how well we do in these situations is important. In normal eyes, we know there is good evidence available both from the NHS and published data. The 0.5 is quite easy. But what about these patients where the accuracy tends to drop? Now, there are some sources of error. One is the axial length, second is keratometry, third is the effective lens position. And if you have a previous RK, we do know the theory behind it, that there's a change between the anterior and posterior curvatures, and we need to also look for smaller optical zones, because if you have a smaller optical zones and you're putting an IOL with a central addition, they will struggle, because there is multiple refractive divisions across the whole pupillary area. There is, of course, a keratometric index error, because there is a change in the anterior to posterior curvature, and that's why the refractive index tends to change. The effective lens position, most of the formulas base it on the axial length itself. So if you have correct axial length and keratometry, the effective lens position most time is an estimation. That's why it's called estimated lens position. And usually 0.25 to 0.5 variation in the position can change your refractive error by about 0.5. Manual keratometry, probably just for the record, but most of us would have shifted to automated keratometers along with very good imaging systems. I have done this in my postgraduate fellowship, but it's not an easy thing getting good keratometry readings in manual if you have had some surgery done. So may not be my most primary approach, but for postgraduate training, it's not a bad idea just to understand the principles. Most of us have shifted to automatic keratometers or with biometers linked with 18 or 32 points, and this gives a very, very accurate amount, because the chance of it changing from this is very accurate. You do measure the central 3 millimeters quite well. The Placido-based Scheimpflug, now you have OCT-based true case, and of course the hybrid, the iTrace. Out of this, my preference is for the Scheimpflug and Placido, because I feel the anterior cornea is an important part of making sure you get the right result. So if you got a good ocular surface, which I think has been mentioned, and then you do these Placido-based systems, it usually helps. Now, there is fair amount of data on EKR in pentacam, which is basically the effective corneal power in the central 4.5 millimeters. So you have that in normal, LASIK and RK. Now, the challenge in RK is you have a very, very wide spread. So 32 to 42 in some of these patients when you get. Now, this is a challenge because you cannot use that. You use the average K and you got a 13 diopter difference across the central optical zone, you will struggle with post-op results. So the ideal optical zone in looking at pentacams or any of these Scheimpflug images is to probably go slightly higher. Usually 4.5 is what I prefer. Now, a topography or a Scheimpflug based image is probably a more reliable system, and you get a larger diameter. EKR in pentacam is there. There is something called TKR in IOL master. The OpScan has something like TMP. This has already been covered, but I think as surgeons, not using this is probably not correct, because the IOL master printout or your biometric printout is basis. Always try and cross check with online. The ASCRS is very good. My accuracy is about 1 diopter for these, and in post RK, post LASIK, I aim for about -1. I would not go through this, but broadly, most of the present online calculators have an accuracy of about 90%, which is actually quite good. This I would just also skip. If you have patients with keratoconus, remember the type of keratoconus is the basis of your results. If you have early keratoconus, it's usually not a problem. But in this, you have to look at visual axis, you look at the steep K and position of the K, because for a keratoconus patient, he may not be looking through the central part of the cornea, he may be looking at a multifocal, it's like a multifocal cornea, so he may not have that clarity of vision. So if it's a very eccentric cone, maybe a good idea to do a topography based treatment, centralize the cone and then try and do treatment, because there are multiple aberrations, predominantly vertical comma and trefoils, which actually affect the quality of vision. This is a broad table which I use. Anything up to 52, your regular Ks would work. Anything beyond 52, you will have poor repeatability. A good idea to actually go in, either put in a ring or do an ablation before you touch the cataract part. I guess there are two parts. Now
Anand,
everything is about AI.
Anand,
Last slide. The artificial intelligence. I think we need to understand the artificial part is the photos on your left. The intelligent part still lies with us, the surgeon. So make sure you use them. In conclusion, be aware of abnormal corneas. Only about 70 to 80% are within 1 diopter. Counsel the patient, maybe for some optimal outcomes. Be aware of the sources of errors. Use topographers wisely and use IOL calculators online. Remember, RK corneas, recheck them, and keratoconus and mild keratoconus, moderate corneas have very good results. I'd like to acknowledge some of my colleagues who helped me out with some of the calculations, and thank you.